presentation. This dramatically improves outcomes and decreases mortality. And most of the time, the causative organism is only identified only maybe a third of the time. Therefore, antibiotics are aimed at treating a broad spectrum of expected pathogens. So you might not get what caused the infection if they present with an infection or sepsis. So, but you should aim at giving a broad spectrum antibiotics. And remember, we said it's an emergency because due to the patients are not able to mount an inflammatory response. So these patients do not demonstrate localizing signs or symptoms other than fever. So and some of the patients will even be febrile. So a high index of suspicion is paramount. Next. So I don't know whether I've past my time, but maybe in your facilities, what challenges have you faced? Okay, so thank you. So be the reason this, okay. So maybe you can tell us some of the, if you have time, the challenges that you have faced managing febrile neutropenia and how we can improve the response in our settings. And also maybe best practices you can share with us. In our facility, we don't offer chemotherapy, so we don't often see these patients. Like this patient came from another facility and was referred to Nanyuki. So it was good for us to be able to treat and manage the patient well. Next. So thank you for listening to me. Be the reason these patients survive chemotherapy.
Thank you so much, Nanci. That was very educational. If anyone has any questions, feel free to just unmute yourselves and directly ask, or you can pop the questions in the chat. Oops.
Can I ask a question?
Thanks
so much, Nanci. It was really interesting to hear kind of how similar actually the treatment for neutropenic sepsis is with you compared to kind of the pathways that we have here. And I kind of am interested in how commonly you might see it compared to in the UK, but those are probably numbers we don't have at the moment. But I was wondering, I guess the question that you've asked the group, I was also wondering what your thoughts were as well in terms of the barriers or challenges you might face to this 1 hour treatment window. So you've kind of emphasized this golden hour of getting antibiotics into a patient with suspected neutropenic sepsis. But have you come across any barriers or challenges in achieving that with your patients? Or have you seen it with other people managing these patients?
Yes. One of the barriers within the, especially the golden hour, in our setup currently is availability of the medication. Usually, the hospital usually stocks some of these medication, meropenem and piptaz, but even currently, they are out of stock. Patients have to buy out of pocket, and they are quite expensive for the patients, and these sometimes delays treatment for them. Sometimes we have to do a bit of fundraising as healthcare workers to assist the families, especially. We know the cost of cancer is quite expensive. So one of the major challenges is usually sometimes getting the medication or it being available at the facility. Yeah.
And how long can that delay things for?
Even 3 days. But yeah, it can delay because if at the moment we don't have, patients have to buy out of pocket, and if maybe a dose they require, maybe if it's meropenem where you have to give 3 times a day, or two, if it's a drug that you need to give multiple times a day rather than a single dose per day, you find that the patient might miss some doses of these drugs. So because they are expensive and they're not, and also they're not the kind of they are not stocked everywhere, because most patients also don't buy them or don't require them. So also getting them from the local pharmacies usually at all order, unless you have to order maybe a special order. Yeah.
Okay, thank you. And is there
I
anyone
have a
else?
question.
Oh, sorry.
Actually, I have a question as well, if that's okay, Nanci.
Okay.
You mentioned we need to collect 2 sets of cultures of aerobic and anaerobic. How important is that, especially given the fact that in resource limited settings, the blood culture bottles are also expensive, and we might not even have one set of bottles available. So how important is the collection, the 2 set of collections?
I think it's important because sometimes some of the organisms that we get sometimes also surprise us in our settings. We get some of our patients are resistant, or some of these not resistant, some of these microorganisms we get uh, are need maybe additional drugs like maybe vancomycin, linezolid, which is also not available, and we might take a very long time without starting a patient on the proper antibiotics without them. But as we said, if we don't have, we can't stop the treatment of the patients. If we have, uh, we can just do maybe a set, maybe from the central and peripheral. Most of the times, actually, we don't do like for that patient, the bottles were unavailable, and we only got 2 bottles on the 4th day of antibiotics administration. So it's important, but sometimes we do what we have to do if we don't have the bottles. Yeah.
Thank you, Nanci. Katrina has a question. Please unmute yourself and go ahead.
Thank you, Nanci. That was really clear and some really nice learning points at the end there as well. I just wanted to ask, you mentioned antimicrobial resistance, and I wondered how much of this you're seeing, and also in persistent fever, how much how much you're needing to use and think about antifungals.
So in our facility, as of yet, we have not had a patient who has had a persistent fever. So not much of antifungals, and unless they have a non-immunosuppression, like maybe in the HIV positive patients, where we have to think about fungal, maybe meningitis. And sorry, I've forgotten the other question you asked.
It was
Sorry.
just about antimicrobial resistance, if you're seeing.
Oh, yes. I didn't take that data, but sometimes we get there's a lot of misuse of antibiotics in our setups, in the Kenyan setup generally. So you find some patients have Actually, we have a resistance to meropenem at the moment. There's a patient who was admitted, was not a cancer patient, but we do have resistance to meropenem. The blood culture came resistant to almost meropenem, ceftazidime, all those drugs. So it is highly likely we get resistance because there is a lot of misuse of antibiotics in our setup. Yeah, not in the hospitals, but patients buy a lot of antibiotics outside for even treatment of viral infections. Yeah, and they prefer the IVs. So if and the people doing business outside are also, they don't care about the resistance, so they just dish out the antibiotics. Yeah.
Thank you very much. That's helpful.
Any more questions? Thank you so much, Nanci. It was a pleasure to have you here, and there was a lot to learn today from you. Before we move on to our next speaker, we would like to share our quarterly spotlight on. So every 4 months, yes, every 4 months, we aim to focus on global health issues through our spotlight on feature. This quarter, we would like to spread awareness about the reduced global health fundings and its impact all over the world. Sorry, my computer has frozen. So, as I was saying, every 4 months we like to focus on global health issues. This quarter's infographic is focused on reduced global health fundings and its impact all over the world. This has been put together by Dr. David Mwangi, Camille, and me. We if there's anyone interested in sharing your inputs, we would like to love to hear about it, and you can get in touch with us. We will later circulate these infographics on the WhatsApp group. It highlights the impacts of healthcare defunding over the world and locally in the Dol Dol Hospital in the Dol Dol County Hospital in Kenya. So we will be sharing this shortly, and you guys can have a look then. Now I would like to hand over to Nadia to introduce our second speaker.
We'd like to introduce Dr. Amy Cooper, who's works at the BRI as a Haematology Reg and a haemoglobinopathy at the BRI. Amy will take us through the understanding of the basics management of complication of sickle cells. Over to you, Amy.
Great, thank you very much, and thank you for inviting me to speak today as well. Is it okay if I share my screen? So this is where I'm testing my technical skills, but hopefully... How does that look? Is that sharing full screen?
Yeah, we can see that.
Perfect, great. So I will be talking today about sickle cell disease. We'll go back to basics, and then we will look at a few of the complications. Actually, I've realized the more I learn about sickle cell disease, the more there is to learn. I could probably speak for 3 days solid on sickle cell disease and its complications. So I'm going to try my best to keep it to 25 minutes. Just a little bit about sickle cell care in the UK. I think it's really important to know about how that works to understand kind of how the care is centralised. So in the UK, there are 10 specialised hubs. So we divide the country, as you can see on the map there. I'm based in the southwest, which is at the bottom left-hand portion of the map. And within those 10 regions that you can see there, there's a centralised tertiary centre which oversees the care of the patients within their region. But then patients can be admitted to any hospital within that region. But if they do need specialist advice, then it's that central tertiary unit that can give that advice. I've been working as a haemoglobinopathy fellow, so I have been essentially just dealing with patients with sickle cell disease and thalassemia. And I've been working at a regional level. Although I am based in Bristol, I've been looking after patients from Cornwall, which is right at the very end of that tip of the southwest that you can see, up to Gloucester, which is near the West Midlands portion of the map there as well. So what we're going to do today, I'm going to take you through a case of a patient. This is based on a real case, but the names and everything else included is completely anonymized. I will talk you a little bit about pathophysiology to then understand what happens when the complications occur, and then what we did afterwards in terms of management. So our patient is a 26-year-old gentleman named Aaron. He has a background of HBSS sickle cell disease. We'll talk more about that in a second. His regular medications that he's on lifelong are penicillin V or phenoxymethyl penicillin. He's on 200 250 milligrams BD. All of our patients with sickle cell disease are recommended to be on this because they're asplenic because of sickling, which causes the spleen to essentially not function from about 9 months of age, and folic acid 5 milligrams, which protects the body as red cells are hemolyzed to allow for ongoing erythropoiesis. His social history is that he works as a maths teacher in a high school. And a bit more about his background. He was born in the Gambia but moved to UK age 7, and he has a fair amount of painful crisis per year, around 2 per year, does come into hospital sometimes, and has had an acute chest syndrome in the past where he needed a red cell exchange transfusion, which we will talk about more in a second. And he's not known to have any red cell allo antibodies. That means he's not clearly had a reaction to a blood transfusion that he's received previously. He's recently moved to Bristol, but we've barely seen him in clinic because he's busy with his job and can't make it into the appointments due to having to work in the school. So we've said that he has HBSS sickle cell disease. What does that mean? Well, I think to understand HBSS sickle cell, you have to really understand the complete basics. So bear with me, I'm going to go back to kind of first day of medical school. We'll talk about what is hemoglobin. So you can see there, that's a hemoglobin molecule, which consists of 2 alpha and 2 beta globin chains. Within that, there's a heme molecule, so you can see 4 of those there, and then they hold an iron molecule, and then it's the iron molecule that reversibly binds oxygen, which allows it to carry and give up the oxygen molecule. And hemoglobin is synthesized from chromosome 16 and chromosome 11. You can see here, I can probably demonstrate with my mouse. Here we're from the kind of embryonic side. So this is when you're an embryo and a fetus, hemoglobin's made from these kind of strange chains. And then we get to the more normal adult chains. And you can see on the right side of here, we have the alpha genes and the beta genes. And this is demonstrated with the eventual hemoglobin that you get. So you can see there at the top, that's hemoglobin A. That's a normal adult hemoglobin that most of us who don't carry or have sickle cell genes will have. And that makes up about 90-ish% of your hemoglobin, the rest being hemoglobin A2 and hemoglobin F there, which are just slightly different hemoglobin chains. So how can that go wrong? There are different ways that it can go wrong. What we're going to focus on is the fact that structural abnormalities can cause problems. The other side of hemoglobin synthesis going wrong is that hemoglobin production can be abnormal, and that's called thalassemia, but we're not going to talk about that at all today. We're just going to look at the structural abnormalities, meaning that hemoglobin is made, but the structure is different to normal. That's because of a genetic mutation, and that causes abnormal hemoglobin to develop. And I've demonstrated that here, so you can see that those beta chains that we had before, it was just beta, now it's beta S, and then it creates a hemoglobin which looks quite similar to the one we saw before, but you can see it's just slightly different in appearance. And then that's the reason why you end up with the problem with sickle cell disease. So you can see at the top of the screen, the hemoglobin S molecule looks pretty similar to the hemoglobin A, which under perfect conditions, it will sit and live happily inside the red cell. Unfortunately, when anything happens to the patient, such as hypoxia, infection, trauma, cold exposure, anything that can put them under some sort of stress, that can cause a conformational change within the hemoglobin as it gives up and takes oxygen. And you can see that it looks kind of more abnormal now, and it's that abnormal shape that means that it can then polymerize. It forms these hard, rigid chains within the red cell, and then it's the red cell here that starts off round, which ends up this abnormal sickle shape. And that happens over the course of the lifespan of the red cell, initially reversibly and then irreversibly. By about 10 to 20 days of the red cell's life, it will look like this. And that's demonstrated here really nicely on a blood film. So you can see that not all of the red cells are sickle shape, but a few of them are there. And you can imagine that that would cause a blockage and cause real problems as they start to build up in number and pass through small vessels. And that brings me on to what they do inside the body. So the main issue that everybody knows about is that they cause vaso-occlusion. So it's that abnormal shape that means that they get stuck within the small vessels. They're rigid, they're non-deformable, things can't pass through. And then that causes ischemia in the area that blood was supposed to be supplied to. That can cause the acute painful crisis that we see. And then in the background, that can also cause chronic or acute organ damage. I think the lesser known but equally as important side effect of sickle cell disease is that the red cells tend to be broken down really quickly. So the normal lifespan of a red cell, as we all know, is 120 days. But with sickle cell disease, because they are abnormal, they get broken down very quickly. And the lifespan becomes about 10 to 20 days, which then just builds into the fact that the patients are anemic. And because the red cells are being broken down in the circulation, that causes vascular damage, it promotes systemic inflammation, and can just lead to the reason why the patient is unwell. So back to our patient. Now, unfortunately, Aaron has presented to hospital. He's come to the Bristol emergency department, and he has presented with severe pain. So what kind of things must the admitting doctor think about when they see Aaron with his painful crisis? So it's really important to think about adequate analgesia. We'll talk more about this in a second. Possible precipitating factors, and assessing for and preventing further complications. So we'll talk through those steps now. So he has been seen and clerked by one of the doctors, and you can see here they've made some notes. So it sounds like he has severe pain in the back, rib cage, and legs. The pain's 10 out of 10. It's not resolving at home, and he has tried paracetamol and oral morphine. He's not had any fevers or infective symptoms. He's struggling to drink enough because of the pain. It's putting him off drinking, so he is a little dehydrated. He's not short of breath and no other respiratory symptoms. So this just goes back to exactly what we were talking about before. The mechanism of action with the presenting complaint here is that something, which we'll find out in a second, has prompted Aaron to have an acute insult, which has prompted his red cells to turn into the sickle shape more often than they had been in the background, and that's caused vaso-occlusion, and that's caused him to end up with ischemia and acute severe pain. So we may have an idea about the precipitating cause because he, 2 days before admission, did go out for what he called quite a long hike up a local hill. And although you can see the sun shining there, unfortunately, as we talked about before, Bristol weather is not the best. And actually, the weather on that day was pretty cold, 15 degrees. And particularly if our patients aren't well wrapped up, that can really cause them to go from having the nice round red cells to then ending up sickling, and that can definitely lead to a painful crisis. So cold exposure is something that we see quite often as a precipitating factor for an acute sickle cell crisis. So a little bit more information about the acute painful crisis. Where can it happen? So any bone really is a site where sickling can occur. That's most common in the limbs, back, and rib cage and sternum. And the type of pain is related to acute ischemia and is excruciatingly painful. So it's really important to listen to the patients and treat them appropriately. And patients might not show their pain as you would expect because they've been living with this kind of pain for their whole life. So what should we do if we do see the patients presenting with this pain? Well, opioid analgesia should be administered within 30 minutes of presentation for moderate to severe pain. But unfortunately, the doctor who saw Aaron initially was a little bit skeptical of him being in as much pain as he mentioned. He said he was in 10 out of 10 pain, but as you can see there, his facial expressions maybe don't show that same the same kind of level of pain as what they would expect to see. And they may be quite reluctant to give opioids. And unfortunately, this is one of the things that we see quite frequently when patients present with an acute sickle cell crisis. Stigma related to sickle cell disease is really complex. And I think that unfortunately, one thing that we see a lot is that people think that our patients are opiate seeking. And one thing that we're really trying to do is to push education to really make it clear that actually it's a very severe, painful condition. And this is something that we need to be treating urgently. And one thing just to kind of show that this is a lifelong painful condition is this is a leaflet that I found from the Sickle Cell Society, which is a UK-based charity which makes really fantastic resources for patients with sickle cell disease and their families. And this is a book for 5 to 10-year-olds, and you can see that in one of the boxes at the bottom of the page there are some suggestions of other things you can do if you're in pain. And I think that just demonstrates the fact that actually patients from a very young age are told to distract themselves, they're told to read, listen to music, sleep, other things that you might not expect to be doing if you're in pain, which you describe as 10 out of 10, but that doesn't diminish their pain at all. It's just a coping strategy. So we're just trying to get that message out really to make sure that people are aware that despite the fact that patients may not be screaming in pain, it's really important that we listen to them and treat them appropriately depending on how they describe their pain. So the doctor who first saw him did escalate to the Haematology Registrar, and luckily the registrar had looked after patients with sickle cell disease before and was aware that there are steps that we normally take to look after them to make sure that we can get them as comfortable as possible. So she suggested that we should look at the pain plan, and that should help with their pain. So what is a pain plan and what kind of guidelines do we follow when we manage somebody with an acute painful episode? You can see here the National Institute of Health and Care Excellence, which is a body which puts out guidelines and essentially rules for us to follow, which we've got a very clear and prescriptive guideline for the management of sickle cell disease. And you can see here that acute painful sickle cell episodes should be treated as an acute medical emergency, and that analgesia should be offered within 30 minutes of presentation. And that's a national recommendation, which makes it really so much easier for us to audit and for us to make sure that we're meeting the standards. So hopefully that means that most doctors will err to the side of giving analgesia as it should be, and not like the doctor that we saw who denied the patient's pain essentially when they arrived into hospital. And then I mentioned the pain plan. So there are a couple of other things that we use when we decide about analgesia. So you can see there on the left-hand side of the screen, that's our local trust guideline. Every hospital in our region does have an emergency department guideline. So any patient with sickle cell who presents should be able to, at least the doctors looking after them should at least be able to access a guideline where it suggests what kind of analgesia they should prescribe. So it suggests essentially following the WHO pain ladder, simple analgesia with paracetamol and an NSAID, and we can give codeine, tramadol as well. And then for moderate severe pain, we may give oral morphine, or we may give subcutaneous we use in our hospitals. So we have different suggestions for doses of subcutaneous morphine depending on how much pain they're in. And then you can see on the right side of the screen there, that's a patient's pain plan, which is completely anonymized, but you can see towards the bottom there's a box which suggests exactly how much morphine the patient should be given depending on their pain score, and they're scoring their pain out of 10, with 10 being the worst pain they've ever had. So we regularly reassess those pain scores and then give more analgesia depending on that. And then if the pain's not under control after about 2 hours, then we would normally speak to seniors and think about whether there's anything else we can do and whether the ward's the appropriate place to monitor that patient. And I should just say, actually, all patients will have one of these within their medical notes so that the doctor looking after them can just go and open it up and knows exactly what to do straight away. So I think it's a really helpful thing for patients to have. Just back to this slide. So the other things that we should do if somebody is receiving opiates is they should have very close observation. So once their pain is under control, we say to monitor observations every 4 hours. And we use the early warning score, which essentially triggers if their observations are particularly deranged, and it triggers for a senior review. Also using pain scores with the 0 to 10 scale, and then using sedation scores just to monitor whether they're drowsy, unconscious, conscious, or sleeping. So that's also helpful to know whether it's safe to give more opiates. And then we do prompt doctors in other departments to speak to the haematology team early so that we can ensure that the management is appropriate. We do give supportive medications alongside the opiates, so antiemetics if they need it, antipruritics, laxatives and naloxone should all be prescribed as required. And then thromboprophylaxis, we use low molecular weight heparin at a small dose. So usually we use enoxaparin 40 milligrams once a day because we know that in patients with sickle cell disease may be at an increased risk of developing a thrombosis. Other things that we can do, so IV fluids are really important. It's really important for patients to be well hydrated, particularly patients with sickle cell disease, because their kidneys, essentially, because of the sickling that happens, means that they're not able to hold onto the urine as well. They have a urine concentrating defect, so they pass large amounts of urine and can become dehydrated quickly. So IV fluids are really important as long as they're not overloaded. A chest X-ray is really helpful if they have chest pain as a baseline. Antibiotics, we have a low threshold for escalating their antibiotics if they do have any sort of infective symptoms or oxygen requirement up from the penicillin that they're on. We normally use coamoxiclav and clarithromycin. Blood tests we like to do when patients arrive, including the usual set, including a CRP to look for infection, full blood count. We try to send a sample to the transfusion lab just in case they do need a blood transfusion. And haemoglobinopathy screen uses high performance liquid chromatography to have a look at how much hemoglobin S is present if they've had transfusions or are on other treatments, for example. And it's really important for us to give oxygen if the oxygen saturations are less than 95%. I'll just skip past this briefly, but NHS England did put out this card, which essentially tells doctors what to do if they're seeing somebody with a sickle cell crisis, and breaks it down really clearly so that hopefully the really important things can't be missed. So our patient, you can see him here, he's been admitted and he's got a plan. His observations look okay, although do bear in mind he's on a bit of oxygen. We'll talk about that more in a second. That's not really been thought about in his plan, although the doctor has recommended that he should have observations every 4 hours. He's had some blood tests done, he's having some IV fluids. The doctor who saw him has also suggested that he should have an incentive spirometer. You can see the little 3-ball machine there, which they're supposed to hold the tube, take a deep breath in and try and move all 3 balls, and that just opens the air spaces. But unfortunately, he didn't get it because there weren't any available on the ward. They wanted him to go for a chest X-ray as well. And you can see here some blood results. So his bloods look okay. His CRP 14, so top of normal range is 5, but it's not super high, so it's okay. And his hemoglobin's normally around that level, 77 or 7.7, depending on the units you use. You can see his chest X-ray there is clear, and his chest was clear on examination as well. So he went to bed and he had ongoing doses of morphine overnight, and he didn't have any other observations done, unfortunately, until 6 a.m. So went about 8 to 10 hours without having any observations. And the next morning, when the nurse came in to do his obs, they found a bit of a different picture. So his blood pressure was low, his rest rate was also quite low, he had a fever, and his saturations were 85% on 2 litres of oxygen, and his GCS was 14 out of 15 because he was drowsy. A chest X-ray was urgently repeated, and you can see that it shows some abnormality, so some consolidation at the right base, and he had crepitations more prominent at the right base. So this is acute chest syndrome. So acute chest syndrome is a complication of sickle cell disease, which is essentially very severe and potentially life-threatening. I have put the diagram of the chest and the lungs there just to remind myself that anything can cause acute chest syndrome. So if you have a chest infection, for example, that can cause some hypoxia, or you have an acute painful crisis within your ribs, that can cause essentially being unable to ventilate as well, or if you are over opiated, then you may not be taking as many breaths per minute and you're hypoventilating, etc., etc. And essentially what happens is that insult happens, there's hypoxia and sickling within the lungs, more vaso-occlusion, more tissue infarction, and then consolidation occurs, there's less gas exchange, more hypoxia, more sickling, and it becomes a vicious cycle that needs to be broken. In the interest of time, I will glaze over this, but acute chest syndrome, the definition is having changes on a chest x-ray and a fever and or respiratory symptoms. So our patient would fit with that. Chest x-ray to be repeated is really helpful because we can see if there are any new changes compared to the last time that they had one, and it's really important to consider escalating to intensive care. So with our patient, it's likely that he wasn't able to take a deep breath because of the rib pain, and he was opioid toxic. He didn't have any sedation scores done, so it's a bit of respiratory depression, and he may have had a bit of underlying infection as well. So what normally happens is actually patients are quite well when they present and they have a normal chest x-ray. Then it might look a little bit iffy later on in the day. And then by the next day, the time that they actually become unwell, that's the time when we first see the changes. And then you can see some sort of magic wand's been waved here, and then things start to improve. So that just brings me on to my very last point. What was that magic wand? Well, actually, the most helpful thing that we can do for patients with acute chest syndrome is a blood transfusion. Other things we do is give oxygen and analgesia, and incentive spirometry is really helpful. So that 3-ball machine, and then treating for underlying cause, for example, antibiotics. But most of the time we do need to give a blood transfusion. So that's either a simple blood transfusion, hanging up a bag and transfusing it, or an exchange where we use an apheresis machine, which essentially removes the patient's own red cells and replaces them with transfused red cells. And it's normally about 8 to 10 bags of matched blood that we give to the patient. So our patient went to intensive care for enhanced monitoring and had a red cell exchange transfusion like I just described. He got better, slowly weaned off the oxygen, then he went home. And then he started on hydroxycarbamide. I don't have time to talk about that anymore, but that is something that we can do to prevent further episodes of acute chest syndrome and sickle cell crisis. So what could have been done differently for our patient? So there was a delay in analgesia administration because of the unconscious bias in some healthcare professionals. He wasn't monitored thoroughly throughout the day and night to pick up the complications early. He was on oxygen when he was first seen before he went to bed. So if that was escalated earlier, then he may not have become so unwell. And then things like incentive spirometry are really helpful to try and open up the airways and prevent lung complications such as that. So that's all. And I'm sorry, that was a real whistle-stop tour. Does anyone have any questions?
Okay, thank you so much, Amy, for fitting a very kind of complicated, broad subject into a clear and concise 30 minutes. I think Lena's got a question in a second. I wanted to just kind of put out to the general audience. So it's been really interesting to hear the management of sickle cell in the UK. And I wonder if any of our colleagues in different healthcare systems or settings have had experience with managing this, and if they recognise any similarities in the challenges of maybe recognition and a kind of appropriate management of pain, and if there are any other kind of things that ring true to your own experiences as well. But whilst you guys have a think, I'll let Lena ask a question.
Thanks, Jo. Can you hear me?
Yeah.
Okay, good. That was really interesting. Thank you so much. I was just wondering, in terms of the acute chest crisis, and the fact that people are presenting with a fever, do you find that maybe it's not recognised that it's an acute chest crisis related to their sickle cell, and maybe blood transfusion gets delayed because they're being treated for pneumonia, and how do you get around that?
Yeah, definitely. And I think it's often forgotten that things such as pneumonia can then cause an acute chest syndrome because of the hypoxia for whatever reason it is within the lungs that causes the problem. So yeah, definitely it can be overlooked. And I think the only way to kind of help that is education and specialist review early. So I think that's why we say to escalate to haematology as soon as possible to give the best chance of recognition of the, I suppose, kind of rare in the grand scheme of things, but very significant complication that we should be spotting early.
Thanks.
Any further questions or comments?
Hi, yeah, I have a question. Could I just go ahead? I mean, in this case, it was kind of obvious that he needs to be admitted because he was on oxygen and so on. If someone with, known sickle cell would present to ED, let's say their pain is relatively well managed and they're not requiring oxygen, would you still suggest that they're being admitted for some observation? Because this also happened a bit later on. I feel like if they then were to go home, they don't have the opioids anymore, they're probably at a quite high risk of deteriorating, aren't they?
Yeah, and that's a really tricky one that we come across really quite often. So I think we definitely don't admit everybody who comes with a sickle cell crisis, but we have a really low threshold too. I think if they'd not really been using many, not been doing much at home to try and manage their pain relief, and then we give them, the kind of basics and some Oromorph and that settles things down, then they're probably quite low risk and can go home. Whereas I think if there's any sort of concern, or they had a lot of analgesia before they came in, and then it's maybe taking a little bit more time to settle down, or there's any sort of concern, or if the patient's concerned, I would always tend to admit them because of that potential risk of a couple of days later then developing the features of complications such as acute chest syndrome, but there are a lot of other complications as well. So yeah, we do tend to have a low threshold to admit people.
Thanks, Amy.
Can I ask one more question? This is more, I guess, if nobody has any comments in kind of making a comparison between one health system and another, I wonder, Amy, if you had any thoughts on Nanci's presentation on neutropenic sepsis and whether, or febrile neutropenia, and whether there was anything that kind of rang true from your experiences of managing it.
Yeah, yeah. So just to clarify, I don't just work in haemoglobinopathies, and I have done some kind of malignant work as well. So we look after patients with malignant haematology conditions and neutropenic sepsis. And I think somebody else had said this, but I essentially could draw a lot of similarities with the way that patients are treated here, and how it sounds like you treat them as well. I think we probably are really quite liberal with antibiotics. There's a lot of antibiotic stewardship, definitely, but I was interested to hear that meropenem is something that you kind of run through the MDT, and that can kind of potentially delay doses and things like that. Whereas I think we certainly meropenem can sometimes be built into guidelines. So I was interested to hear kind of a lot of similarities, but then certainly some differences as well. So yeah.
Thank you.
Thank you so much, Amy. That was very well laid out.
Thank you.
And thank you everyone for attending. Thank you, Amy. Thank you, Nanci, for such wonderful and educational presentations. We have posted a feedback form in the chat. Please fill the feedback form to receive your certificates. You may have some delay in receiving them, but you should be receiving them. I will also be posting the link to our WhatsApp group for further updates. Our next grand round is on the 8th of October. It's scheduled already on the 8th of October. So we will see you then. Thank you everyone once again for attending, and thank you, Amy. Thank you, Nanci. Those were really well and great presentations.
Thank you.
Thank you.
Thank you.
Just, I think with your certificates, if you do fill in the feedback forms, which would be really helpful for us, normally the certificate auto sends with your name on it, but I think there's a slight technical hitch. So this month, your name won't be on the certificate, but we'll try and fix that for next time.
Thank you.
Thanks all.